Welcome everyone. Welcome everyone to the Aspire first ever embryology online forum. I'm Keshav and today I'm joined by a very good friend and a colleague of mine, Yani from Australia. And we're so glad that all of you can join us for this one of a kind experiment that we're doing on social media, Yani. Uh, before we get started, I just have one thing to say to you. This is a forum, and we are going to be actively using the chat to hopefully get your questions and deliberating them with our experts. So please post in the chat box, whether you're joining us from Facebook, Instagram, or on LinkedIn. Put your questions in the chat, and we will pull the interesting ones in and post them to our experts. Over to you, Yani, for introducing our panel of experts today.
Right, here we go. Welcome everyone. Good evening, good afternoon, or maybe good morning, everyone. Apparently, we have really widespread geographically. It's very excited, as the chef said. It is our very first experiment, but we really hope this experiment gonna give us very unique value. Now, so let me introduce our incredible expert panel for today. There are people, who have seen all sorts of challenges in the lab, and more importantly, and they are going to help us to solve the real problems today. So, for the very first, we have Dr. Sui Liang Liao, who is the scientific director of the Virtus Fertility Center in Singapore. Welcome, Dr. Liao.
Thank you.
So Dr. Liao, please can I ask you to use one word, a single word, to summarize your approach to embryology?
My approach is patient-centric.
Well, that's a two word, but that makes sense. Excellent. All right. So our next esteemed expert is Professor Arthur Chan, who is a professor at ONG and the lab director of the University of Texas Health Science Center, USA. I hope, Arthur, you had enough sleep to join us. I believe it is 3 a.m. at the moment. Really appreciate your time. Welcome, Arthur.
Yeah, my pleasure.
Yes, so Arthur, can I please ask you your one-word approach for embryology?
I would say evidence-based.
Right.
I think we should change the question to 2 words.
There's a little dash in the middle.
Maybe.
Yeah, but that makes sense. Thank you so much. Well, now our last but not least, my best friend and colleague, Dr. Kenji Izoi. So Kenji is the senior scientist at Kato Ladies Clinic from Japan. Kenji, welcome. And I'd like to hear what's your one-word approach to your embryology.
Very difficult to answer. So, all of my life.
Excellent. That's a very long one word, apparently. But now I think pretty much we are ready to go. We are super excited. Now I'm going to hand over to my partner host, Keshav, to start our very first theme on embryo culture grading and the blastocyst.
Yani, what's your one word first? Let's try and get that as well.
I think it's care.
Care. Yeah.
Care, because we are patient-centered. I think everything should be for the best interest of our patient.
Absolutely. And I think this is what sums up today's forum. I think all of us are joining with such varied experiences, but the core gist of our practice is patient-centric, doing our best for our patients, caring for our patients, etc. And that's one of the reasons why we are hosting a troubleshooting forum, so that we can find out where we are going wrong, and through our experts also get answers to things that maybe we were not thinking about. We've got lots of people joining in. We've got people from India, from Germany, from Perth. So hello to all of you. Good day to people from Australia. And this forum has been designed by you guys. So we did a survey, and based on that survey, we've now come up with 4 themes that we will be discussing with our experts. and these themes range from all the different kinds of practices that we do in embryology. So I'll be reading out the first question that has come up from Fazila, and she's from Advanced Reproductive Center, and she basically writes, why do good grade day 3 embryos show slowing down for in their development till day 5? So you have a very good day 3 embryo, but it's not progressing as expected to day 5. I'm going to go to Dr. Liao first because he has the most experience amongst all of us. You've actually spent years looking at all of this, Dr. Liao. Does culture conditions, gas levels, temperature drifts, the media batch variability, the incubator performance, do these things matter when we are looking at slowing of embryonic development?
Yes, it's one of the factors. But first of all, we must look at define what is good day 3 embryo. Is it at 8 cells or 10 cell stage, or is it because the cells, let's say for instance, a 6 cell or 10 cell, are they uniform in shape and all those things? So because that is very important. Now the second thing is that how do you assess the embryo? Or in other words, which incubator are you using? Are you using the conventional incubator like benchtop, or are you using a time-lapse incubator? Now, for a conventional incubator, of course, to assess the embryo development, you're going to take it out of the incubator, put it on the microscope, and then put it back. And then the next question is, how often do you assess it if you use a conventional way? Well, so if you assess the developed embryo for every day of the embryo development, that can affect the culture environment in the embryos. When you take it out, then you check the embryo, you expose the embryo to the laboratory environment outside the incubator environment. It affects the pH, it affects probably temperature and all those things like that. So the more often you handle all these embryo, you may affect the development from day 3 to day 5. Yeah, but let's say now if you have this time-lapse incubator, on day 3 it looks very nice, it's cell, but somehow to day 5 it cannot reach blastocyst, probably a morula or maybe an increased number of cells, that's all. Yeah, so but then you have to look back at, is it the development, we go back from day 0 or day 1 onwards, is it development, is it a reverse cleavage, or is it a fast cleavage? That will indicate the quality of the embryo, that something is not right in there.
Absolutely. And Dr. Liao, if I ask you here, whenever you see this within your own setup, what would be the first 3 things that come to your mind that you would want to check? And these could be takeaways for our audience.
Yeah, the first 3 things that you will check, let's say you use the conventional, and first thing is check, because if you were to do everyday checking of the embryo, then you should reduce that. All right. So in other words, you have day 1 checks for fertilization, avoid checking on day 2, then check on day 3, because it's for some of you, if you use sequential culture medium, that's the time when you change to fresh culture medium, or we use one-step medium, then that is okay. And then reduce the time of checking when you take it out and expose it and handle it with care. That's very important. Yeah. Other than that, and then you look at the incubator itself, whether the temperature is right, because on the indicator it may show 37, but the temperature may not be 37. So you have to use a reference thermometer every morning to check whether it conforms to that. And another thing is to look at the pH. Now you may, on the indicator, you may see there is a 6% CO2, but is it 6% CO2 or 5% or more? But to help to indicate this, perhaps you can use a phenol rate medium on a dish somewhere to guide you and look at the pH. So all these things can help to troubleshoot. Yeah, some of these are very cost effective and cheap. Yeah.
Thank you, Dr. Liao.
Yes, Dr. Liao, so you very correctly highlighted time-lapse and morphokinetics. So interestingly, we actually got a colleague from Singapore. Her name is Doreen. She shared an intriguing case, right? So in this case, she mentioned that the embryo has displayed completely typical morphokinetics. But what happened is actually the patient unfortunately ended up with a trisomy 21 pregnancy. So what does this all tell us about? And what's the limits we're measuring? Do you have any insight on this?
Well, you can't actually for trisomy embryo, it behaves exactly like a normal healthy embryo. You can't really tell the difference between a euploid or aneuploid embryo in this sense. Yeah. So
Yeah.
by looking at the morphokinetics, you can't tell at all. The only thing that
Yeah.
you can show is to do a PGT before the transplant.
Yeah, definitely. Because we also have Kenji and Arthur also have very broad experience about the time lapse. Do you have any comments about that?
Yeah, so morphokinetics reflect the division timing and the dynamics, but it cannot directly detect chromosomal abnormality. Yeah.
Excellent.
There are like publications out there, Kenji, which have started looking at like ploidy status with certain morphokinetic time points, like time to start of blastulation, or time intervals between like T2 and TSB, etc. What's your take on that? Will in the future this become a predictive model?
Yeah, so previous study reported that, so for example, so time to H cell stage or blastocyst stage are significantly correlated with the ploidy status. But so even using these parameters, it's really difficult to predict the ploidy status. So of course, we can, as there is a strong correlation between these parameters and the ploidy status, but we cannot use these parameters as in the clinical setting.
Yeah, thank you, Kenji. Yeah, Arthur, do you have an insight about the morphokinetics? And also, there's an interesting question popping up from the audience. Also talking about the biggest challenge about the lab streamlining process across different departments. I think somehow the morphokinetics and time-lapse culture could have contributed to this. What's your thoughts?
So I think it has its place in our lab, but we cannot just rely on the morphokinetics. So it's like a morphokinetics, like time lapse, and it start popping up maybe like 10 years ago, then suddenly become a hype or trend, and then gradually kind of dying down a little bit. And now we are looking back to use it as a part of our tools, but not the sole tools or the major tools. Seems like.
I think time lapse itself, there are people who really, really love it. And then there are people who are only like focused on completely on evidence. And because we don't have enough evidence to suggest that it is improving outcomes, they would be like, oh, what's the point? So I have used time lapse personally, and I think it's a tool that I can personally like. I have experience in saying this, that it really standardizes practice amongst embryologists, and I would want to use this if I have multiple clinics. I would want to use this TAMI as a way to streamline like at least the embryo grading and the embryo selection component. Is also a great tool for incubation, is what I feel, and again allows us to standardize the incubation system completely. We will touch upon your question throughout this forum, because I think your question is quite a broad question, and it will fit into all different streams. And maybe after every theme, we'll take up this question and we'll come back to what is one thing that can streamline, let's say, ICSI, which will be our next theme. But before I move on to the next component or the next theme of the panel, I want to come back to all experts here with, let's say, the single most impactful thing an embryologist can do from tomorrow that will affect or improve their blastulation rate. We can start with Dr. Liao.
I think the single most thing is that from the beginning itself, because the egg is a major component that you must handle. To me, or as I always tell my students and my staff, handle the egg with TLC, meaning tender level care. Yeah, from the beginning, from time of aspiration to assess the egg oocyte, and then handle all the way to fertilization. That is very important because if you as temperature change, if there's a sudden temperature change in the medium or whatever, it affect the cytoskeletal system and also the breakage of the meiotic spindle, and all this will cause embryology or fragmentation and all this. So tender loving care, handle the egg properly. Yeah, that's the main thing. The first thing is to handle that properly.
Kenji?
Yeah, so as Surya mentioned previously, so it is essential to routinely monitor temperature and the gas concentration in the incubator and to recalibrate them whenever necessary. So because so even minor fluctuation can influence embryo development. And in addition, so each center should carefully evaluate and select the culture media that fit its own laboratory setting and the treatment strategy. So rather than assuming one system works equally well everywhere.
Arthur?
Yes, so I echo both Kenji and Soilian's assessment, and I would like to add on one small tip is to optimize your micromanipulation skills. So like a good XC and bad XC, it can just maybe affect 10% or 20% of fertilization rate, and also good biopsy, no signal or a good signal. So the XC itself can actually affect a lot of not just the processes rate, but also good processes rate. So I would like to add on that.
Awesome.
Right now we have another question coming through, which is very exciting. So now our audience is interested in knowing the experts' recommendations. How would you use, either the embryo genome activation timing or the embryo morphology, as well as the culture strategy, for example, group culture and single embryo culture? What would your advice about, in this bigger picture of the embryo culture? What would you recommend? So maybe we start with Dr. Liao.
Okay. I think genome activation, all those things, yes, you can be critical, but to me, it's not the. You have to consider all the factors actually. Now, before time lapse was introduced into the whole laboratory, we use conventional way, and I'm the advocate for group culture rather than a single culture system, whereby because you understand about autocrine and paracrine factors that the embryo secretes into the culture medium. If you have the group culture medium, these paracrine autocrine factors can help the rest of the embryos to grow as good synchronized their growth and development. But if you have just a single embryo culture system, the so-called synergistic, the effects of the autocrine paracrine may not be able to. I mean, they don't have that factors to help it grow as well. It should be in a group culture system. Yeah.
Anything to add, Kenji or Arthur?
So same with Surya, but so we did in vitro experiments comparing the single embryo culture and the group culture, and so there are no significant difference between these culture system, but so group culture showed a slightly higher developmental rate. So yeah, if possible, so I recommend you group culture.
Yeah, same with me. My internal data show that the group culture has been better than the single with micro drop setting. However, I also run the time lapse like a machine, so there's not much option I can do with group culture. I have to do single embryo culture in the time lapse. Yeah.
Excellent. Yeah, I think this is very interesting points. Probably that will be expanded in our future sessions. So now we have to move on to our next topic. So for the next topic, we're gonna look at the ICSI gamete handling and the sperm challenges. So before I start, I'd like to invite the audience to put in a thumbs up or raise your hand in the chat to see, has anyone ever seen a situation where you have done all the right thing and all the eggs look so normal and every ICSI procedure went so smoothly, but you still ended up with a very, very poor fertilization outcome next day? So we leave 10 seconds in the chat room to see if we got any feedback.
I will raise my hand. This is a common occurrence.
Yeah. Okay. Right now, I might just stop here. So yeah, as Kashav and myself, I have the similar experience. It's miserable. We never tell what has caused. But interestingly, one of our submitters from the members, her name is him or her, Lo Jia-yi, had shared one example. So they had one experienced embryologist and 20 eggs collected. They used even calcium ionophore to activate, but they still found failed fertilization. So let's unpack. So what could have been going? So I'm gonna go to Arthur. So Arthur, you have dealt with all sorts of challenging situations with the sperm. So please, can you walk us through your checklist about, how do you analyze the failed fert situation?
So yes, this is very interesting case and kind of on the extreme scenario, but we really hate to see the total fertilization failure, and it's hard to talk about that with the patient. So usually when we do the ICSI, after ICSI, we want to check that is that truly fertilization failure or like a technical situation. Is that first it could contributed by the sperm, so sperm trigger related, or is the oocyte quality or cytoplasmic confidence? And also when we think about the using the AOA like INO4 in these cases, then it probably can help the sperm issues. But if there's any cytoplasmic maturation problem, then there's not much we could do. So AOA has its usage, but also a lot of limitations. So I would say in this case, if we try the AOA and the sperm looks okay and everything looks fine, then I would say maybe split the case and try something else to work on the oocyte as well. But in some cases, you really can, all you can do is probably get a donor oocyte in some cases.
Very good point. So we actually have another submitted case. I might go to Dr. Liu. So this is about a prolonged sperm culture before insemination. So in this report, the couple had a combination of, unfortunately, PCOS and oligoacetinoteratospermia. All right. So in this case, only 3 grade 1 embryos at the end from a really, really good egg cohort. Do you think the incubation time for the sperm going to explain it?
I think yes, incubation time of the sperm, prolonged incubation time will degrade the quality of the sperm, because now I think it's in the olden days, I call it was believed that when you prepare the sperm, you have to expose it in 37 degrees all the time before you use it. Now, to understand that, because the sperm has limited energy, all right, and if you prolong it for 4 hours in the incubator, it swims aimlessly and energy. Secondly, they will increase in the production of free oxygen radicals or reactive oxygen species that can harm the sperm. Probably they can degrade the sperm DNA, and that could also affect the fertilization. May not affect the fertilization, but affect the quality of the embryo. Yeah. So for my advice is that for this type of thing, sperm preparation, you can delay it. So what we do here is that now you can ask the man to produce, let's say, the sperm at 8 o'clock in the morning, but you decide to do ICSI at 12 o'clock. So you can just leave the sample, semen sample, in the room temperature, about 25 degrees Celsius, and about 1 hour, half an hour before you start the denuding of the eggs, you get your staff to prepare the sperm. So, and what we do is that after denuding the eggs, we set up, the sperm will be ready, and then immediately we will use that sperm to fertilize the egg. There's no need to denude the egg and let the egg rest for 1 hour before you do the ICSI. Right? So all these things are very technical. And usually for eggs from PCOS, the quality is somehow compromised. You compare with those women who have a non-PCS condition. So now with this PCOS and with long incubation, prolonged incubation of sperm, it's a double whammy. That's why it can cause mainly affect the development of the embryo, and the grading of the embryo, or the grades of the embryo can be affected.
Yeah, brilliant. Yeah, so how interesting. We actually had another colleague who her name is Jessie. She raised another similar severe oligoastenoteratal case. So in her case, interestingly, the pre-washed sperm, it was motile, but became immotile after the gradient processing. I might just go to Kenji this time. So Kenji, have you seen this before? And what's your recovery protocol?
Yeah, so not very often, but yes, so it does happen. So if motile sperm become immotile after gradient, so I would first suspect preparation-related stress, and excessive centrifugation, temperature fluctuation, or pH instability may significantly affect sperm motility. And especially in extremely low count samples, so OAT cases, so even standard protocol may be too harsh. So in such cases, I would review the entire preparation process. So centrifugation speed, time, media type, and the temperature control. And reducing centrifugation step, lowering G-force, or shortening process time, or even switching to a single layer gradient or direct washing method may help minimizing mechanical and oxidative stress. And another important consideration is reactive oxygen species. As Sverre mentioned, so severe OIT samples are particularly vulnerable to oxidative damage during processing. So minimizing exposure time and avoiding repeated centrifugation is critical. And if no motile sperm are available at the time of ICSI, so viability assessment become essential. So techniques such as host hyperosmotic swelling test or laser-assisted selection can help identify viable but immotile sperm. And in selected rescue situation, so pentoxifilin may be used to transiently stimulate motility. However, the approaches must be used cautiously. So chemical situation or osmotic stress may induce additional biological risk, including oxidative stress, or functional impairment. Therefore, the decision should be individual and ideally discussed with the clinical team beforehand.
Absolutely. Thank you, Kenji, for that detailed answer. We have a couple of questions coming in from the audience. I think the first one I'm going to post to Arthur first. Arthur, when you see sperm issues, would you suggest using microfluidics to get a better sample? And this one is coming from Abhinav from Mauritius.
Yes, the sperm sorting sample. Actually, I can combine this one with the previous question about if the sperm crashes after the gradient. So gradient has proven that to actually introduce more the RS and also DNA fermentation, and also in some cases the sperm all died after gradient. And in those cases, I would say we can try the sperm sorting device either that way, or we can do a kind of like a micro swim out, like we can make those like a crosshair shape, like a drops in a dish. Then we can search like a single sperm, like a pickup from those. Because if the sperm quality is on the borderline, we can use sperm sorting devices, membrane sorting or microfluidics, and those has been working pretty well in the literature and also in my lab. But however, if we have those like severely crashed sperm sample experience, the next time we'll probably just, if not considering the sperm sorting, we just put down the mic like a micro swim out and pick up the individual sperm. And also, as Kenji mentioned, pentaxiphyline. Also, pentaxiphyline was mostly used for the testicular biopsy samples, but however, we've used that for the PESA and also ejaculate samples, and sometimes it works, sometimes it doesn't. Then, yeah, there's not much harm to try it.
Yeah, I think a lot of people are switching over to microfluidics, and it's really helped in optimizing work efficiency. That's one big component because you're not spending so much time centrifuging semen samples, and you don't have staff dedicated to just keep a track on what's happening and what step they're at. But we're also looking at data emerging, which says that through some of these devices, the sperms that have been sorted have a very low DNA fragmentation index, and ultimately it's something that probably might be beneficial. We'll still wait for more evidence to come up. I have another question, and after this we can move on to the next section. And this maybe Dr. Liao can take this question up. So this is from Vicky, and he's asking whether a male partner who has severe OATs with almost 90% of head defects in the sperm, is it wise to proceed with a TISA or a TESE, especially because there are a low amount of sperms within the semen sample?
Well, okay, that's a very good question. That's a very practical question. In fact, for men with severe OATs, if using the ejaculate, normally I would suspect the quality of the sperm in terms of its DNA, it probably has DNA damage than those sperm in the testicle tissue. So in this case, if the severe OATs, rather than using the ejaculate from this man, I'll go for TISA, or this because whatever the sperm is in the testicle, they are less exposed to any of the reactive organism species or have a lower DNA damage. That can help to improve the quality of the embryo and pregnancy outcome. And we have a lot of patients having this, and we are, in fact, in this case, almost 100% of these cases we go for TISA using the testicular sperm, and we're getting very good outcome.
Are you also using IMSI, Dr. Liao, for such situations? Would that
Yes,
be
we
a good
do.
option?
Yes, IMSI is a good option, but if you use the ejaculated sperm from this severe OATs patient, you probably see more of vacuoles. Now, the shape of the sperm head doesn't matter. It doesn't really affect the outcome in the end, because the head of the sperm is just for the attachment of the egg and all those things during natural fertilization. But if you do IMSI or ICSI, it doesn't matter. So most important is that if you use IMSI, you look at the vacuoles of the head in the ejaculated sperm. If a high number of vacuoles on the head, that means that the sperm would have a high DNA damage. But in the testicle sperm, you will seldom see all these vacuoles in the testicle sperm. Yeah.
Excellent. All the very good points. Thank you, everyone. But before we move on, we have another very, very interesting comments coming through. So in this comment, we got asked, it's something called laser-assisted immotile sperm selection. I wonder if any one of our experts have experience with this technique.
I've tried it and it doesn't work. I've never seen it. Like I don't know if I'm shooting the laser at the right point or whatever, because the concept is that you shoot the laser at the tail, and the tail, if it's a live sperm, the tail should wiggle or twitch. but I've never seen it. Dr. Liao, Arthur, have you tried it out?
Well, yeah, I
No,
have
I
tried it,
haven't.
but it doesn't really work as well. If you want to find out whether the sperm is viable or not, immortal sperm viable, I think the best test is the host test, hyperosmotic solution test. Yeah.
Time tested and I think evidence based. I think that's something that we should be advocating.
Yes.
Yeah, wonderful. Yeah, brilliant. We have a lot of great discussion this session, but I'm probably going to wrap up with this comment, which is overall, there's no single variable that can tell the whole story. I think it is always a combination, right? There's so many aspects we have to consider. But now we move on to the next one, which is really something that keeps a lot of clinicians and embryologists sleepless over the night. So that is about what happened when we have a perfect embryo but still not implanting. All right,
Yeah.
let's move on. I'll hand over to Keshav then.
Yeah, so you're actually framing it absolutely perfectly, Yanni. So you have a euploid embryo, you have good morphology, good morphokinetics, you transfer it and it doesn't work. What do you do next? Is there something that you're missing? What would you analyze? Anyone? Arthur, Dr. Liao, Kenji, whoever wants to begin first.
Let me answer first. Because embryo transfer is the critical, the main critical part of it. Now, first of all, of course, you look at the clinician. Is the standing of embryo transfer is good. You probably may have placed the embryo, too close to the cervix or too far to the other end, and probably just flush it, and as you flush it, the embryo tends to rotate, and then they may cause damage. The second thing is also the receptivity of the uterus itself and endometrium, whether it's receptive to the embryo, whether it's synchronized with the stage of the embryo. That is very important. Now, the third thing people is talking about is the NK cells, which is very controversial to me. Yeah, whether there's these NK cells recognize the embryo as a foreign body, it may kill the embryo in the uterine environment and may not implant. Yeah, so these are the things that may happen. Yeah.
Yeah. So we have a comment here from Ramya, and what she is mentioning is that so she's seeing diploid embryos being transferred and they failed, but when they did an HLA typing, is that something that worked? Is this something that's done routinely?
The HLA, human leukocyte
Yeah,
antigen.
so HLA incompatibility
Yeah,
resulting in failure.
I don't think this one happens all the time. Yeah. I think we don't do all this HLA thing, even with donor embryos or donor eggs. It doesn't really happen. Yeah.
Because from what I have read, I have never done this, but from what I've read, it's only done where you would want to create an embryo which is matching to a sibling so that you can get save your siblings. That's the only indication that I know of for HLA typing, and that's also something that's not allowed in most countries.
Yes. So for this question, Dr. Keshav, this the person who posed this question is recurring implantation failure. Is it from the same patient herself, or from generally from other groups of patients also? So you then have to look at whether the transfer is done properly, whether the embryologist has loaded the embryo properly, and all those factors. Yeah, a lot of technical.
Yeah, and even clinical things like endometrial receptivity. You've already mentioned NK cells and immunological factors. There's a lot that needs to be covered. When we talk about the laboratory side, I think Danilo's paper does mention a lot of these points where euploid embryos fail, and like things like rebiopsy, revitrification are things that can slightly compromise outcomes. What do you feel?
Who's answering, Arthur? Or me?
Yeah, it's still you, Dr. Liao.
Okay. Well, rebiopsy embryos I think there's not much issue if it's handled properly because we have embryos that have rebiopsy and get transferred and get pregnant and with live birth. So there's no, I don't think there's an issue here. I think it's more of the handling of the embryo because from what I've seen from other laboratories practice. Now, some of them will have load the embryo in the lab and then move to the OT with the catheter in there and pass to the doctor. So the distance then from, let's say, from the lab to the OT is about a few meters long. And by then there's a sudden drop in the cold temperature, and then that could affect the embryo. Even though the embryo is healthy, nice, and but if the temperature suddenly drop to room temperature, it may cause stress to the embryo, and we put it in, embryo may not implant. So what I would suggest is that you try to narrow the embryo transfer distance. Yeah, like what we have in inverters here is that in the ET room we have one crib and the incubator is there. So the embryo that has been selected for transfer will be placed in that incubator. And we wait for the doctor to put in the guiding catheter first. Don't load the embryo before that. So once the clinician has confirmed that they tell you please load the embryo, then the embryologist will take up the dish, put into the crib, and load the embryo and pass it to the pass it to the doctor, which is about the distance is about 1 meter away from the crib to the doctor, and then this helps to shorten the distance and less exposure to the embryo to sudden change in temperature, which is very important.
Thank you, Dr. Liao.
Yeah, it's very. If I can add, I think I do agree with Dr. Liao. It's so many aspects. There's a lot of great point to look after. I just want to quickly add about the repeated biopsy and vitrification, because one of our senior embryologists, Kate, she did really good job on a recent meta-analysis where we pulled out quite a few studies put together, and we found really for those inconclusive embryos, actually the double biopsy plus double vitrification do reduce some live birth potentials. So that's double vitrification with or without double biopsy. So even purely double vitrification also, has an effect with the subsequent outcome. So I just to make the it was, I think it's on human production 2 years ago. If anyone in the audience is interested, you can look it up. It is the free access.
Awesome.
I can add up just the importance of a trophectoderm though. So sometimes people focusing on the euploidy. However, after biopsy or like a rebiopsy, like a revitrification, the trophectoderm might get damaged. Then without good quality trophectoderm, the implantation probably will get like a lower rate of success. So
absolutely. Arthur, while we are still at it, do you think that the technique of the biopsy itself can damage the embryo, or the skill of the embryologist is important? What's your take on that?
Yes, definitely. Yeah, the skill level and also the proficiency of the embryologist is very important. So if you, for example, I would say everybody can biopsy a perfect, like a high quality embryos. But if that's on the borderline, for example, the cell lysis, and you have to kind of make a compromise how many cells you want to get, or you decide to drill another hole to go from the other side of the embryo. So oftentimes that rely on the experience. So I would say, keep like a learning from senior embryologists and see those difficult cases. That would be the best way to learn.
Yeah, we have an audience question here, which pertains to this topic itself. It's from Atyan. I'll read it out to you, and Arthur, maybe you can take this, or Dr. Liao can take it. During embryo biopsy, how should we manage cells that stick to the tip of the biopsy pipette? They have tried gently tapping the pipette, but the cells become more attached. And if they're tapping it hard, then the cells also rupture. So what should they be doing?
Maybe Arthur, you answer that first.
Yes, the tapping is very interesting. So the one technique I learned about maybe 2 years ago was using actually the pen, not the fingers, to tap the holder. So it works pretty well and it's actually more gentle and it get the cell detached very nicely. And also if the tapping caused the rupture of the cells, I would definitely go to biopsy and get more cells. And usually when you see those like cell ruptures, not every cell rupture, maybe it's 3 out of 5 or 2 out of 5, then you just get another 2 or 3, then pull them together. I think
Yeah,
that
you
works
still
in most
collect
cases.
you still collect them and you send them for analysis. Does this affect
Yes.
the mosaicism rate by some like means? Because I read a publication which mentioned that if you're shooting too many laser shots and there's a cell lysis and all, it can increase the rate of mosaicism.
Yes, it definitely could. But however, from what I heard from those vendors, like genetics labs, they are getting better in distinguishing those the intact cells and those noises.
Okay, thank you.
Yeah, excellent. Right, so I do see one relevant comments previously from our Korean colleague. I think the name is she. Let me find it. Anyway, so yeah, so San Woo Shim from Seoul, Korea. So I think they have highlighted the importance of genetic stability of the embryo blastocyst. Uh, however, I'd like to highlight that there are instances which is also submitted through from the members, Dr. Ravi, who raised the unexplained infertility. So they have highlighted that there will be repeated reimplantation, recurrent implantation failure, even if you have good quality euploidy blastocyst. So even including donor cycles. So in this kind of challenging situation, I'd like to go to Dr. Liu. How would you console the patients about this kind of situation?
Well, usually what we do is that when we do also we call a post consult after the first cycle, we usually sit down with the clinician and the couple, and we will go through with them. And what we can do is that the next thing is okay implantation failure. Even if it's a euploid embryo, then we have to look into discuss with them, particularly more to the doctor side, how to probably looking at the clinical the situation, whether the endometrium, everything is all prepared properly, and from there we counsel the patient. Because um, on the lab side, what we can do is that because we use time lapse and then we have all the recording of the embryos, we can show them, how these embryos develop, they are normally, and the best we can do. And then when you look at the laboratory side and there's no issue, they are quite contented. The only thing now is for the clinician to explain to them how best we can do to improve the implantation. Yeah.
Yeah, I think we'll take just one last question for this section and then move on because we still have two more themes to discuss. So this one's for Kenji. Kenji, you let's say have 5 to 6 euploid embryos which are available for you for transfer. Now, how will you select the embryo now? Because all of them are euploid. Would you look at the quality of the trophectoderm, quality of the inner cell mass, or would you look at morphogenetic parameters? If you're looking at morphogenetic parameters, which ones would you prefer? Short 1 minute answer, please.
Okay, so in our clinic, so we basically use our internal embryo grading system, and so these which are based on the developmental speed and the blastocyst morphology. And if we have several euploid blastocysts, so we select the blastocysts according to this internal selection model. And if this selection, so if embryo scoring is same, so we use IDA score to ranking the embryo. yeah. So I mean, so we are prioritizing the embryo to be transferred. It so
Based
developing
on
the speed
based
and
on
more.
IDA score.
Yeah. Yes.
Got it.
Internal grading system is first, and then IDA score.
Got it. Thank you.
Mm.
Yani,
Yeah, so we're probably gonna move on to the next session from here. But the point I'm trying to make, so we're actually quite lucky. So we're living in a very fast developing era with the technology nowadays. All right. So, but probably within the room, because we come from every country, different kind of a setting, we might at different stage of this kind of technological development, especially AI, which is a very hot topic. Right. So I'm probably now gonna put Arthur on the hot seat now. So, all right. So we got a question, Arthur. How does a lab director actually evaluate the AI platforms? And when they are looking at different platforms, what they should be asking the vendor? What's your thoughts?
Yeah, that's a really big question. So there's a few areas I would like to look into when I evaluate those like AI platform. So all those AI tools, they say they can increase the implementation rate. They have a better U-ploy prediction. Also, it's very interesting that the only sure way to predict to know the U-ploidy is actually by the PGT, but not those AI tools. And also, they will have their own like a proprietary embryo ranking, and of course, they can reduce our operator variability because you rely on machine, not human. So there are a few questions I would ask when I'm talking to the vendors. First is there a peer review or multi-center validation showing that I actually improve the live birth rate, not just embryo ranking? Because a lot of those tools, they only use a single center, even though they are big centers. But how do we generalize those into our clinic? Because many of us were small clinics, we don't have a capability to validate all the data or build out our own algorithm. And also, second, that's also talking about the because we don't have the training data set. So how does that generalized? And
Yeah.
also, how about the clinical gain in like a live birth, like live birth rate, and also what's the cost? How much do we have to spend on the AI tool to increase maybe, for example, like 3% or 5% of our live birth rate? Maybe we can look into other things first to increase that 5% before we actually apply to the AI tools.
Yeah,
That's really important, Arthur. I think one more thing that I add here is that you look at where the data has been collected from the population set. You've already mentioned that it may not be we may not be able to generalize it for our patients. I think it's important to look at that profile as well.
yeah, and also I would like to add because Arthur mentioned the randomized controlled trial. Because from my memory, so far there's only a couple of trials available in the publication, but one thing is for sure, it definitely improved the workflow. It do the grading quicker, probably. But so far, we probably haven't observed significant improved live birth rate by using AI. Apparently, there will be a long way to go still. But now I have some more specific question for Kenji. So we have a question from Doreen, one of our members. They're asking, Kenji, when you select the embryo between morphokinetics, AI, or PGT, how do you choose from them? And so what's your tips about developing a selection tool?
Okay. So yeah. So we use the morphology, morphokinetics, AI, and the PGT. But so I see these two as complementary rather than competitive, and we so morphology assesses structure, features, and the morphokinetics evaluate developmental timing and the division dynamics, and the AI can detect complex patterns that may not be easily recognized by human eyes. and the PGT just assess the chromosomal status. And each tool has its own strengths and limitation. And so instead of relying on the single parameter, so we aim to integrate for more balanced and informed decision making. So in our clinic, so we combine the morphology, morphokinetics, and the AI, and we just use PGT for the cases with repeated implantation failure or recurrent pregnancy loss or advanced maternal age.
Yeah, definitely. So we've talked about a lot of AI. So I think I'm probably gonna come back to a more person kind of question. So we are still embryologists. We're human, right? So we've got a colleague. I think her name is Fazila. Right. So they asked a more human-oriented question. I'll probably direct to Dr. Liu, who has the most experience within the group. So when you onboard a new embryologist, and also when you manage the lab performance, particularly in the smaller clinics, what's your approach from a leadership perspective?
Okay, well, of course, when you have a new embryologist coming in, or I call it the junior embryologist, either fresh from university or from another IVF center joining in. First of all, of course, orientation to what you are doing, because whatever she acquired or learned from another laboratory may not be suitable for what your center is doing. So first of all, we have to assess that. So that usually, they say for a new, fresh graduate who wants to join in, so to me, selection of sperm is very, very important here. So first of all, the junior, we call it junior embryologists, who have to spend about 6 months in the embryology diagnostic lab to identify, so that you can identify or differentiate between a good sperm and a bad sperm. All right. Then after that, slowly move into culture, IVF, periculture medium, and observation of all the procedures, and later on do some test exercise using discarded eggs or discarded embryo for freezing or for ICSI or so on and so forth. So along all these passages, there is always a senior mentoring that junior all the way, and we always observe, and also we also assess the performance of this junior embryologist until we are happy and confident that she can handle the case later on. Yeah. So this is how we mentor them. Yeah. As for those we have some experience, we still assess them going through embryology, but more of the fast track if she or he performs better, and then from there we usually about 6 months to 1 year she can do. She be allowed to do the clinical cycle by herself. As for the junior, probably she may take about 1.5 to 2 years for us to be more confident for her to do one complete clinical cycle.
Brilliant. Right.
Yeah.
So we are running. Yep.
I want to add one point here.
Yes, of course.
Spire has created a certification exam for embryologists.
Yes.
Take that into consideration for all of your juniors. We have 2 levels now, beginner as well as intermediate. The intermediate one launches in China. So do register your embryologist for that. It does assess competency. We have a logbook. Lots of things are done there.
Yes. I agree. Totally.
Yeah. Very valuable program. Now, all right. So we're running out of time. We'll be very quick to just address one last aspect, because this is very important. It's from our member. So our member wants to know, how do we control our lab environment and the QC? I'm gonna make it very brief, but also challenging to our panel. I might just ask each one of our panel's experts use 15 seconds just to give a very brief advice. What should our member do to keep the lab environment under control? Maybe Dr. Liu, then Arthur, then Kenji?
Yeah.
Okay, first of all, we have to follow all the protocols, and most important, the environment in terms of air quality, the handling, and reduce contamination and whatever it is, and make sure that the flow of the procedure is a smooth flow. Levels from oocyte retrieval, ICSI, embryo transfer, freezing should be the laboratory design should be designed in such a way that the flow does not interrupt any of part of the procedure or cause any error, increase the risk of accidental knocking or loss of the gametes. Yeah.
Excellent. Right. Now we are nearly to the end. I believe every members now had a really good time, and we generated a lot of discussion. Now, before we let our experts go, I put another challenge for them again. So 1 sentence for each person. What's the most important thing you want our embryologists to take away from today's session? Maybe now I'll reverse. I'll start from Kenji, then Arthur, then Dr. Liu.
Kenji first.
Kenji?
So, so Swedio first, please.
Maybe Dr. Liu?
I think I will go first. And till the time that you guys think. I think what we've understood today is that there are so many variables in the embryology lab that our focus cannot be just on one thing. We have to actually keep a bird's eye view on everything in order to probably control our outcomes and give a consistent performance. I think that's my takeaway.
Yeah. And in addition to Keshav, we must always continue learning, because that is either through looking into literature as well as discussing with our fellow embryologists, learning from the seniors, and attending courses, which is very important, especially Aspire certification course, which will help to upgrade your knowledge and skills in your practice.
Arthur?
And my recommendation would be, so after conclusion of everything the audience has learned, start from something easy and small steps. Find the easiest one you can implement in your lab. And also, once you start implementation, adhere to that. Set up acceptable range, and if something out of range, try to fix that. Because I've done so many inspections for accreditations, and you always see that they set up a very nice protocol, but they don't care about any out of range stuff. Then they say, oh, that's just happen one day. No worries about that. But I would say, looking into those small steps and adhere to your protocols.
Excellent.
Kenji and Yanni will take in comments from the both of you.
So, very small sentence. So, when outcomes are unexpected, the answer is really one variable. So structured thinking and system level review are more powerful than quick fixes.
Yeah, thank you. That's a very good one.
Yeah, so I'm probably gonna say very simple. Be the human. We do our human perspective, no matter how AI advanced. That's the key, the core hearts of our job, and we look after our patients. So yeah, that's my only.
Totally agree with you.
Absolutely. So I think this brings us to the end of our forum. I would really like to appreciate Dr. Liao, Arthur, and Kenji for being phenomenal today. And I would want the audience to join in appreciating their presence and sparing their time for all of us today. Also, Yanni for co-moderating this first forum with me. We'll be coming up with more forums later on in the year. So if you're an Aspire member, you will get a survey form soon, and you can post your questions, your cases. The next one we're thinking is on mentorship. So there should be a lot of questions on career progression, career tracks for embryologists, trainings, etc. And this really helps us in getting a feel of how APAC is actually doing as far as the progress of our field is concerned. So really thank you so much from the bottom of our hearts, and we look forward for more interactions. Yanni?
Yeah, and just by the way, to remind our members, please remember we'll send the recording of this session after this within 48 hours with 5 takeaway messages summary from our experts. All All right. So in the meantime, while we prepare for our next session, please send through your comments and your questions and the challenging situation. We'll really look forward to see you in a short period of time. See you next time. Bye bye.
And do follow us on all social media platforms. See you guys. Bye-bye.
Bye.
Bye.
Bye.